Hello, this video on asthma is in conjunction with what we're studying in week 3 for NU 621, Advanced Pathophysiology. This one is also in the form of a quiz with some explanatory features as well as some tips for treating patients with asthma. These are the references that I have utilized in the preparation of this video. So feel free to access them as they are all in the public domain. Alright, question number 1. Which of the following is recognized as a common factor that can contribute to asthma or airway hyperreactivity? Number 1, gastroesophageal reflux disease. Number 2, lymphangitis. Number 3, hyperaldosteronism. Or number 4, thalassemia. And again, I'll give you a few seconds to think about it. Alright, the answer is 1, gastroesophageal reflux disease. You are probably all familiar with many of the triggers of airway hyperreactivity. There are environmental allergens that could be anywhere from a caustic substance in a workplace to plants and pollens. Another trigger is viral respiratory tract infections. There's exercise-induced asthma. Hyperventilation can trigger hyperreactivity of the airways. GERD, chronic sinusitis or rhinitis. A drug sensitivity such as aspirin, which is a big one. NSAIDs, beta-adrenergic receptor blockers, including eye preparations. Obesity, environmental pollutants, occupational exposures, irritants, and emotions. Which of the following characteristics distinguishes a severe acute episode of asthma? Number 1, the oxyhemoglobin saturation on room air is greater than 95%. Number 2, pulsus paradoxus is not observed. Number 3, the heart rate is greater than 120 beats per minute. Or number 4, the patient is breathless when exercising. The answer is 3. The heart rate is 120 beats per minute. Many of the symptoms you are familiar with, such as breathlessness at rest, patient is unable to eat. Again, remember, we're talking a patient in severe asthma attack, and it is an acute attack. So they're not going to feel like eating. They're going to be breathless at rest, and they can only speak in simple words or phrases and not in complete sentences. They are sitting upright. They become agitated because of a lack of oxygen. Their respiratory rate is often greater than 30 breaths per minute, and their heart rate is elevated at greater than 120 beats per minute. They use their accessory muscles to help them breathe, and they may have suprasternal retractions. They have expiratory and inspiratory wheezing. Pulsus paradoxus is often present. That's where they take a deep breath and their blood pressure drops 20 to 40 millimeters of mercury. Anything less than 10 is normal, but 20 to 40 is significant. And their PO2, if you're measuring it on room air, is less than 91%. Next question. Which of the following treatments is only recommended for patients with severe persistent asthma? Number 1, short-acting beta agonist, only as needed for symptoms. Low-dose inhaled corticosteroid. Inhaled medium-dose corticosteroid plus a leukotriene receptor antagonist. Or a high-dose inhaled corticosteroid plus a leukotriene receptor antagonist and an oral corticosteroid. The answer is 4, high-dose inhaled corticosteroid plus a leukotriene receptor antagonist and an oral corticosteroid. Treatment for asthma using the accepted evidence-based guidelines is a stepwise therapy that's adjusted according to severity. It includes treatment for acute exacerbations as well as long-term control. And there are 6 steps. The first step is intermittent asthma. short-acting beta agonist only as needed, usually in the form of an inhaler. Step 2 is mild persistent asthma, and what's recommended for treatment here is a low-dose inhaled corticosteroid. They have a short course of Advair, or sometimes they'll get, depending on the physician, he may just give them prednisone, but the guidelines say a low-dose inhaled steroid. Step 3 is moderate persistent asthma. You have a low-dose inhaled steroid, and you add a long-acting beta agonist or inhaled medium-dose steroid. The next step is moderate to severe persistent asthma. Use inhaled medium-dose corticosteroid plus a leukotriene receptor antagonist such as Singulair. The next step is severe persistent asthma, and as you look at this, you'll notice that Step 5 and Step 6 have the same title, which I know can be confusing, but the last step in the stepwise therapy is really ramped up for the same condition. So the milder form of severe persistent asthma requires an inhaled high-dose steroid plus a leukotriene receptor antagonist. If it's severe persistent asthma, you have the high-dose inhaled corticosteroid plus a leukotriene receptor antagonist plus an oral steroid such as prednisone. And of course, with patients who have severe persistent asthma, you really should consider determining what they are allergic to and treat accordingly. Next question. Which of the following is not an indication for hospitalization in patients with asthma? Number 1, a PO2 level less than 60 millimeters of mercury. Number 2, status asthmaticus. Number 3, asthma complicated by sinusitis. Or 4, confusion, drowsiness, or loss of consciousness, which is not an indication for hospitalization. Number 3, asthma complicated by sinusitis. Status asthmaticus is an acute severe asthmatic episode resistant to appropriate outpatient therapy, and it is a medical emergency, required hospital management. But for asthma complicated by sinusitis, the findings from a repeated assessment after 3 doses of an inhaled bronchodilator determine whether the patient needs to be hospitalized. The other 3 choices require hospitalization. If you have any questions, you can refer to your text or the national guidelines, which are available in multiple places, such as guidelines.gov or the American Lung Association. You can feel free to call me on my cell phone. The number is in the syllabus, and I want to thank you for your time.